Dr. Jayanta Biswa Sarma, after graduating in medicine from Guwahati Medical College in 1990, Assam, obtained his first master's in bacteriology and virology, molecular microbiology from Manchester University in 1996, and was awarded MRC Path Medical Microbiology by the Royal College of Pathologists, London in 2003. He joined as a consultant microbiologist at Northumbria Healthcare NHS Foundation Trust in 2003. Subsequently, he was conferred FRC Path 2008 by Royal College of Pathologists. Dr. Sarma developed a keen interest in antimicrobial resistance and healthcare-associated infections and obtained a diploma in hospital infection control, London School of Hygiene, Tropical Medicine, 2010. His PhD at Guwahati University in 2011 research was significant in discovering a novel mechanism of resistance, NDM1, in Guwahati Medical College and Hospital, Assam, which led to the collaborative publication of one of his highest cited papers in the Lancet Infectious Diseases in 2010. Dr. Sharma has co-authored several scientific papers in this area of antimicrobial resistance and infection control. Dr. Sharma also obtained CMI Level 6 certificate in 2013 in Senior Educational Leadership Development from Durham University. Subsequently, he completed a postgraduate diploma in medical education from Dundee University in 2018. He served as postgraduate training program director in medical microbiology in the Northern Deanery in 2010 to 2016, and also served as the joint head of School of Laboratory Medicine from 2016 to 19. Health Education, Northeast. His keen interest in molecular microbiology and microbiome led him to pursue his second MSc in genomics from Newcastle University, 2019. He was a clinical lecturer at Newcastle University from 2003 to 2019. Since June 2020, he is working as lead consultant microbiologist at the Mid-Yorkshire Hospital's NHS Trust. He is a visiting honorary faculty at the Center for the Environment, IIT Guwahati, India. Dr. Sharma regularly writes popular articles to promote understanding of various social and scientific issues in Assamese vernacular media. An accomplished author, he has published a compilation of essays and 3 translations of epics from English to Assamese. He is the founding chief editor of one of the highest circulated Assamese youth magazine, Baro Utoro. Also, he is involved with several social enterprises, the latest being Assam Healthcare Cooperative Society, a flagship enterprise of which he is the founding vice chairman.
Thank you, Mansi, for your kind introduction. And Honorable Vice Chancellor Gohai Madam and my esteemed colleague, I can see quite a few familiar faces, my senior colleagues and my quite a few junior colleagues, and obviously the new students, the new, I do not know most of you personally, but as you know, I am from Guwahati, I belong to you, and my association with the Sankaradeva University has been quite long as well. It goes back to the days of its inception. So today I thought I'm not an expert in ethics and I am not the best person to speak on this topic. But given the nature of this series of webinar, I thought it probably would be a very apt topic, as Madam Gohai mentioned. So I picked up this topic, and what I'm going to do today, I'm going to give you a very brief introduction of how to deal with ethical issues, and then I'm going to be speaking about 3 specific ethical issues that modern medicine kind of challenges us with, and I'll be citing few examples. So I think overall you will have a kind of a flavor of what medical ethics is about, how it can help us to navigate our path in our journey of modern medicine, and hopefully it will interest you, and you will pick it up as your interest, and do your own research and study and build on this. So let me bring up this slide, and with this slide share. Okay, so ethics in medicine. So okay, what is medical ethics? Madam talked about evidence-based decision making. In modern medicine, we make our treatment decision based on evidence. So similarly, medical ethics recognizes the relevance and importance of values. So it is not about evidence, but it is about values in medical decision making. So in treatment decision, it is our evidence coming from medical research, but ethics is about our values of the society. So big moral issues like euthanasia to everyday medical issues, how limited healthcare resources can be distributed, equitably, that could be an ethical issue. So all the mundane issues like a policymaker come across in terms of, how I distribute this limited pot of money for this treatment or that treatment. There is ethical dilemmas in making those decisions. Similarly, big things like euthanasia, is it ethical to kill a person? So these are the topics we deal in medical ethics. So other things like cloning, genome editing, reproductive technologies, these modern avenues of medicine throw up many ethical dilemmas. So ethics is the navigator. Ethics is the navigator. It allows us to deal with these issues and navigate in a safe manner. So techniques of what are the techniques we apply in our effort to arrive at a safe kind of ethical decision. This is the argument. Argument is central in medical ethics, as well as we all know, argument plays the central role in law. But there is a difference, in law, we have a foundation of arguing. We argue within the limits of the statute. The laws are stated in a statute, formulated by the parliament of the land. So we got a basis. We cannot go outside that framework. So law in argument in law is limited to that framework of statute, or maybe previous examples of judgment. We frequently refer to past judgment to arrive to make our argument. So that is in medical law. So in law, but in ethics there is no set principles. There is no such framework that these are the few principles that we have to be limiting ourselves. We are essentially free to make our argument in a given context. In fact, argument is to debate what are the ethically right and relevant principles in a specific situation. It's rather than saying that this is the principle and we have to abide by that principle all the time. Yes, most of the times we abide by our principles. Every profession got its principles, but we are not limited by that. In a special circumstance, we can actually debate about the principle. Is that the right principle? Do we need to change our principle in this given context? So you can see the scope of argument is much more wider in medical ethics. So law is restricted by statute, as I said, precedents, but ethics can question old principles and seek new moral ground. Just let me. So therefore, at times, ethical consideration that require an issue to be dealt. So therefore, sometimes actually law, says hands up. We cannot deal with this issue. Please go back and let this issue be decided within the medical professions. So that is within the remit of medical professions, that you decide amongst yourself in your best considered judgment as a bunch of professionals, what do you think would be the right step to follow in this particular situation? So sometimes actually law steps back from the issues of medical ethics. So basically, to summarize, ethics is not limited by a set of time-tested principles. We can question the principle, and how best to do that in certain occasions, it may be the best thing to leave it to the professional judgment. So that's what we on occasion we do, but most of the times we enter into vigorous argument, what is right and what is wrong. Because principles does play a big role in terms of our argument, let us quickly go through the principles of modern medicine. What are the basic foundations of modern medicine, the ethical principles? But remember, we are not limited by these principles. In a new situation, in a new context, we might need to change one of these principles. Maybe we come up with new principles. So that is the power of ethics that allows you to actually deal with any new situation. But the fundamental principle, as a doctor, we are guided by 4 fundamental principles in modern medicine. First is respect for patient autonomy. So it is the patient who actually decide that I prefer this treatment or that treatment or no treatment at all. It is up to the patient. And as a doctor, our role is to make him, to help him to make that decision by giving him all the relevant information. So next principle is the principle of beneficence. The promotion of what is best for the patient, usually judged by the objective assessment of a relevant healthcare professional. So you see, you can see there is a dilemma. So if it is in the best interest, that is what we should be guided by, then actually patient may decide that I do not want your judgment in regards to your decision that this is in my best principle. You can see there is a bit of a conflict. As a best interest, as a doctor, I decide that this operation is good for you, but at the same time, patient may well decline. You see, it is quite immediately you can see there is a bit of conflict there. Then the third principle is non-maleficence, that is avoid harm, do no harm. If we can't do any good, at least we should not be doing any harm. That is the third principle, which is interrelated with the beneficence principle, doing the best thing for our patient and not doing any harm. It goes side by side. And the fourth principle is the principle of justice, which is not different from ordinary application of justice as we understand by its common term. Basically, but in regards to healthcare, this is what we call distributive justice. How we divide a limited pot of money. As a minister, as a healthcare policymaker, as a director, as a principal, you've got a limited pot of money and you want to do everything, but you can't. So you have to decide that I am going to do A, not B, but there may be an ethical argument involved there. Why not B? Why I am prioritizing A? So you have to justify your decision, in an ethical manner. So these are the 4 principles. So fourth principle, if you think about in a hospital setting, maybe if you concentrate too much on, say, prioritize your resources on the ICU, giving the best care to the ICU patients, maybe you are compromising in giving your full attention to the preventative care. Maybe this is what it is. Sometimes it's a big thing. What medicine you are going to. In country like United Kingdom, there is a body called Clinical Excellence, National Institute of Clinical Excellence. They decide which medicine to be available in national health system in England. And they have to then deal with these ethical issues. Why I am choosing this cancer drug, but ignoring that drug for, say for some sort of cardiac disease. You have to be able to justify that kind of decision. And medical ethics is your navigator. This is quite this navigation itself is complicated here, because my navigation right and left arrow is masked by some messages. Okay, all right, yeah, okay. So what are the toolbox then? How we arrive those ethical decisions of right and wrong? First is obviously we have to recognize between the facts and values. Facts are facts, but values are different. You know what we should be doing. What is the values in this particular matter? The societal values. You know, sometimes facts and values are at times maybe difficult to separate. We confuse facts with the values and values with the facts. But facts are facts and values are values. So we need to be able to distinguish between these two things. Most of the times it is not difficult, but sometimes there may be a problem. Then reasoning from principles. I have outlined 4 principles, you know, in the previous slide. So maybe when we arrive, we are faced with a dilemma, we can refer to our principles. So that is one of the ways that we refer to the principles, and we see whether our decision is going to be in keeping with the principles. But I already told you that principles are not sacrosanct. In a new situation, when you are faced with a new challenge, you might need a new principle. You probably would be questioning your old principles. But most of the situation, we reason from the principles. You know, that is one of the ways that we can deal with ethical decisions. Then it is really important to define terms. For example, if we are talking about euthanasia, as you will see when I bring up the issue of euthanasia, it is really important to clarify the decision, because by the term euthanasia, you might think I am referring to active euthanasia, but there is something called a passive euthanasia. There is something called involuntary euthanasia, and similarly we got voluntary euthanasia. So these all things, all different. There are a few different concepts. So when we are talking about, we need to be coming from the same background, essentially, that when I say euthanasia, you exactly know what I am meaning. So it always pays to clarify, to define the terms. Then elucidating concept. Concept are sometimes could be abstract. So we need to actually ponder on the concept and try to understand what is the, you know, what this concept actually mean. Then case comparison is another useful way of clarifying ethical dilemmas. Then we can do thought experiment. Philosophers frequently resort to thought experiment. Not the philosophers, even the scientists. You probably know about Einstein doing thought experiment. So in quantum mechanics, sometimes you cannot actually do real experiment, but you can do thought experiment. It's a very useful tool for philosophers and for that matter, when we discuss ethical issues. Then logic is obviously logic is the foundation of argument, but logic can be fallacious. It is something, an argument can be logically very consistent, like mathematics, but actually it could still be a fallacious argument, fallacious logic, because logic flows from a foundation, from a premise. If the premise is wrong, then everything is going to be wrong. Your conclusion is going to be wrong. But it actually looks very logical. It is easy to fool people. Look, this is the logic. This is why I am doing this. You know, so you need, we obviously we apply logic all the time, but be careful. There are many fallacies, especially the premise. If the premise is wrong, then everything is going to be wrong. But it is very difficult to spot sometimes that you are speaking from a false premise. Then that is the number 8 is obviously I mentioned in relation to logic, that when we apply logic, we have to be very aware that there are fallacious logics, and we need to be able to spot those fallacies. But you know, those tools are not enough. We have to go beyond the tools, and that is, there is a danger. The tools are about rationality, but if rationality practiced in isolation of other virtues can, like bureaucracy, become rigid and inhuman. So bureaucracy is like law. It goes by the rationality, by its own rationale. But if we don't practice bureaucracy with a bit of heart, then it becomes inhuman. So we need to be in ethics, we go beyond these set tools and apply a bit of our heart and mind. So applying heart and mind, it's really, really important. Without right sensitivities and awareness of the context, you see the context word has come up few times by now. Context is really important. A context I face in England would be totally different to what you face in Guwahati. You know, context, societal context, everything is so different. So something right for me here may not be right for you there. You know, that is, we really need to understand how context makes a thing, you know, may actually influence your ethical decision. Then consistency and moral enthusiasm can lead to bad decisions, actually. You know, without the sensitivity and right awareness of the context, if you just want to become consistent and you think yourself, oh, this is the moral thing to do, no compromise, actually you may arrive at bad decision. Really, really interesting, you know, philosophical reflection. You see, we always say being moral is good. We always say be consistent. Don't do this thing today, that thing tomorrow. Yes, it is generally true, but there are subtleties involved. If you become too consistent and too kind of, you know, morally upright, sometimes you may actually arrive at a bad decision. So that's why we need wisdom. Let wisdom guide. That's the Royal College of Psychiatry London's motto. So what do we understand? What is wisdom? It's a good definition here. Wisdom is a combination of moral integrity with an almost intuitive grasp of the likely outcome of our actions. And it requires an understanding of how people are likely to react to a situation. So it is very intuitive. A wise person intuitively kind of knows that this will be the consequence of this action. You know, how you become wise. A wise person most of the times, so we become wise by experience. You know, experience plays a big role in us becoming wiser. Every day we can be a little wiser, and therefore learning from experience. But again, I'm returning back to the definition, you know, how you recognize a wise man. A wise person most of the time does the right thing with right consequence. You know, that is the definition of a wise man. In medicine, what does it involve? It involves a good grasp of how a particular patient and his condition will respond to different management strategies. You know, a wise doctor would kind of, he may not be able to prove it by some kind of evidence, but by experience, by his heart, application of his heart from his experience, he kind of intuitively know that putting this patient on ventilator is actually not going to serve the best interest of this patient. This is my patient. If I put him on ventilator, because my protocol says that, you know, next step is the escalating the treatment, putting somebody on a life support machine. But a wise doctor would know that the consequence would not be very good, and he would explain that to the, you know, to the relevant, you know, person. He would discuss within his team, and they would come at a ethical decision that I am not going to do this. So that's the wisdom. And we need imagination. Imagination is needed to understand perspective and emotions of patients, their families, and other members of the team. Art and literature can help to enlarge our imagination. Actually, as a doctor, we can enlarge our imagination. Being interested in art and literature, we should be reading things, you know, novels and things like that. Then creativity. Creativity is required to develop an argument, to consider possible counter arguments, because the technique of, you know, ethics is, you know, when we discuss about ethics, you give an argument, I will come up with a counter argument, then there will be counter of the counter argument, you know, but you would not be able to imagine a counter argument if you don't apply creativity. You have to be able to think outside the box. It is the interest of the ethics that we enter into vigorous argument. argument, counter argument, countering counter argument. Only then we will be able to, and if I am taking a side, I need to anticipate what counter argument you will be coming up with. So creativity is necessary, to become more creative in arguing, So creativity, wisdom, imagination, we have to go beyond the set tools of rationality and be able to apply wisdom, imagination, and creativity as well. So now that's the bit of the foundation, how ethical issues, ethical dilemmas are kind of dealt with. But without examples, it is very difficult to understand. Those are a bit theoretical. So I'm going to discuss three issues. First one is the eugenics. Then I will move on to euthanasia. Then the third topic would be about what we call the problem of the non-existent. Those who are not born yet, who do not exist yet, but even they throw up ethical dilemmas by virtue of what we can do nowadays in terms of pre-selecting our embryos. A lady can come and she may decide to select an embryo with a condition of blindness. She's within her right. As a doctor, what do we do? Shall I prevent her? No, you can't bring a blind children into the world. Do I have the right? Is it ethical? So I think that last topic is quite interesting. Actually, it brings up issues that intuitively we think, oh, a blind child should not be brought into the world, even though I got the choice. But we will actually see that this is not so easy. There are ethical dilemmas involved. But let me first move into the eugenics. I'll going a bit fast because there are quite a few slides and to finish it within time. But as I said, basically, this is a very introductory kind of an opening remark or lecture type of thing. It is to give you a flavor, to generate a bit of interest. And obviously, in this series, I hope university would be bringing up a lot of practical ethical dilemmas, actually practical ethical dilemmas. Euthanasia, eugenics, these are probably slightly more distant, although from time to time you would still encounter these ethical issues, but maybe this is in a near future. This is in near future going to be very relevant. But there are many ethical issues you actually experience in everyday clinical practice. I think those are the issues we should be discussing in this forum. And let me clarify one thing. Few things are very clear, black and white. That as a doctor, we should not be taking commissions from the laboratory. It is not an ethical issue. It is a matter of law. If I take commission, I should be liable to going to the prison actually, because that's a clear breach of existing law. So those are, although we kind of tend to think, oh, that doctor is unethical because he takes commission. It is actually not. He's a criminal. Ethical things are a bit, there is a scope of arguing that what I think ethical, you may not think is ethical. These are more nuanced matter. But taking a commission from a laboratory is outright criminal. So we are not discussing those kind of issues here because those are black and white. We know as a human being, we know as a doctor that this is no go. We can't, this is a Lakshman Rekha. We can't, go and accept commission. For that matter, we cannot take money from Pfizer and fly to Switzerland to attend a medical conference. This is outright wrong. Anyway, so coming to eugenics. There is a philosophical movement called transhumanism. And this movement aspires to improve the humanity. But how? By selecting, who will come into existence. So essentially, we would allow certain people to come into existence and deny others. And that is our means to, to improve the human race. It's not a new concept, but actually transhumanism is a movement going on today. They are making new argument, and we ought to consider their argument as well. So this modern transhumanism believes in the desirability and possibility of a human race radically superior to the present, which they refer to as post-humans. So they are not talking about, barbaric means that, okay, you cannot give birth to these children, but they are applying a bit of a nuanced approach, but their aim is still to improve the humanity. Post-humans far exceed the virtues and capacity of current human genius, and even be capable of enjoying a higher state of consciousness and bliss. So this is not a wrong dream to dream. This is a right dream that tomorrow humanity would be far more superior than what we are today. That's not a wrong thing to dream. It's a matter of probably how we arrive at, we choose how to proceed. So that's the background. That is the philosophical underpinning why a group of people, wants to practice eugenics. They want to improve the human race. Nothing wrong in that aspiration as such. But when we talk about eugenics, immediately what comes to our mind is the horror of the early 19th century. So eugenics, kind of for majority of us, is like, oh, eugenics, my goodness, it's a forced sterilization of blacks and of people who we think less superior to ourselves. So that's the immediate picture that comes to our mind. It is the science of improving human hereditary qualities, but as I said, it evokes the horror of early 20th century, a forceful state-sponsored program of sterilization of individuals deemed imperfect. It peaked in Nazi Germany in between 1933 and 45. So each association with the Nazis, with the Hitlers, it immediately gives us a very bad impression about eugenics, that it is something unethical. So we'll examine if it is really the case. But before I go into the arguments, let me show you a few slides from early 20th century. And you see, eugenics was a very, very mainstream policy during early 20th century in America and in Germany, in some parts of Europe as well. You can see, sorry, I'm talking about early 20th century, actually early 19th century, but by early 20th century, people are taking cognizance of it, that this is not good, and then it was abolished. So you can read this plaques. By late 1800, Indiana authorities believed criminality, mental problems, and I don't know what this means, pauperism were hereditary. Various laws were enacted based on this belief. In 1907, Governor J. Frank Henley approved first state eugenics law, making sterilization mandatory for certain individuals in state custody. This was happening in America, but this was obviously abolished later on. Look at this. This is how state actually propagated eugenics, publicized. It's like a social marketing, how eugenics is good, how we should not be, if I am suffering from some mental problem, as if I should not be giving birth to any children. That is how people were brainwashed. People were encouraged, given certificate. This is like applying marketing techniques. And then people were really brainwashed. I don't know whether you can read this placard. These are a group of people. I can see people of different age, intergenerational people, young people, old people. One of the placard here saying, I must drink alcohol to sustain life. Yeah, I have to drink alcohol. I am an addict, but I am questioning now, shall I transfer the craving to others? So meaning, should I be giving birth to any children? So as if addiction is a hereditary problem. Then this one is saying, could the prison's asylum be fitted, prison and asylum be filled if my kind had no children? So assumption is that prisons and asylums are bad. If bad people like me, not allowed to, give birth, then we would not need any prison and asylums. Then I cannot read this sign. By what right have I children? So I'm an uneducated person. Do I have any right to give birth? You see, these are the ordinary people. They are promoting eugenics in that sense, that every bad virtue is coming from our hereditary property. But obviously at that time genetics was not understood in as we understand now. So therefore we nowadays think, we apply nuanced judgment. But this is what is called old eugenics. It was a blunt kind of approach, that if you are a bad people, then your children are going to be bad as well, and you have no right to give birth. So that is what practice in country like America. Can you imagine? So what is new eugenics then? So new eugenics is different. In recent times, ethical arguments based on libertarian ideology have been advanced for human enhancement. So no force. Here parents are given all the right. The parents should voluntarily take advantage of the reproductive technologies such as embryo selection and genetic engineering to enhance the mental and physical attributes of their progeny by pre-selecting or even genetically engineering desirable genetic traits. So this is a new argument. It's a nuanced argument in the sense that, no, we are not going to force you. As a parent, it is completely up to you. But I think you are supposed to do this. You are morally obligated. So this is the argument some proponent of new eugenics make, to say that it is morally obligated to bring the best offspring to the world as a matter of choice and reproductive liberty. You can see that they got a point. But we are not forcing you. These are the technologies, these are the avenues modern medicine has given you. Take advantage of it and make sure that the children you are going to give birth is a perfect human being, is a superior human being. So that is the argument of the new eugenics. So now what we'll be doing now, I have put the foundations. The old eugenics is bad. We don't need any, it's a very black and white. You cannot force people. You cannot make people, forcefully sterilized. That is wrong ethically, no question, But let us see whether new eugenics, which is throwing up a new challenge, modern medicine has given us the tools, and a group of people is promoting that this is good. Adopt this modern technology and enhance your children. If it needs to be a genetic engineering, whatever means, or pre-selecting embryos, there would be 5 embryos. We can genetically test each of those, and then we would select the best one of it. So that's the argument. So, but we will now in next few slides we will critically examine if this is going to be the right approach, especially in the when we got CRISPR technologies, we can really actually engineer our babies. So is new eugenics in fact not so new? So it may be actually, we'll see that it is actually not so new. It is the old stuff wrapped in a new argument. So this is the first kind of sort of objection. Even if libertarian ideal is protected, whether a situation depicted in Aldous Huxley's novel Brave New World or American science fiction Gattaca, or for that matter, emergence of a privileged species, Homo deus, as warned by Yuval Noah Harari, could be avoided. You see, these are dystopian prospects. It sounds so good. It is up to you. If you want, you adopt this technology, bring a very perfect child to the world, or don't do it. I'm not going to force you. So that is the argument of eugenics. But we will examine, even if that argument is, accepted. Yes, that's good. You are not forcing me. But even then, can we escape this dystopian prospect? Let me very quickly tell you about this film, Gattaca, 1997. This is the story of a guy called Vincent Freeman, a man conceived without the aid of reproductive technology. So the background of the film is that in that society, most of the people, especially the rich people, they chose reproductive technology to bring to this world the best possible, human being. But this Vincent Freeman is an unfortunate guy. He is from a poor background, and his parents couldn't afford to resort to a technology and give, bring to this world a perfect Vincent Freeman. So he's an imperfect guy. So it is his story, who works to overcome his genetic disadvantages compared to his enhanced counterparts in order to achieve his dream of a career in space travel. So he is dreaming of a career in space travel. He's disadvantaged by his genetic makeup. Actually, he was made disadvantaged because all the rest of the people got the perfect genetic makeup because their parents could afford to do that for them. So he was put in a disadvantaged position. So this is a very powerful film, which kind of gives us the first glimpse that what it could be like in future. The idea of human dignity and justice go hand in hand. This is what the film argues. The liberal eugenics introduces yet another instrument of discrimination and stigmatization in our increasingly unequal world. And that's why this fictional story is not without a basis. The film exposes another fallacy, genetic determinism, that humans are nothing more than the aggregate of their genes. That is, I am just a series of codes written in, DNA. I'm not more than that. So, and also there is a bit of a, even today, genetic determinism is very problematic. Do we really know that this is a gene for intelligence? Do we really know that this is a gene for becoming a great sportsman? We don't know. Our science is still very unsound. If we are hasty to label that this is the gene for intelligence, we may actually commit, a lot of wrong. We would go back to the old days of old eugenics. So this is Brave New World. Some of you must have read this novel. I haven't read this novel, but I know the summary. So this is set in a futuristic world state whose citizens are environmentally engineered into an intelligence-based social hierarchy. So society is kind of stratified based on ability of the people. But these people are not normally born people. They are born in artificial wombs, not in mother's womb. These are the people how state is kind of producing children as if like a chicken being produced in a nursery. So human beings are produced like that, and they were stratified into a hierarchical society. And that was possible in that Aldous Huxley's imagination. In that future state, there were technology like reproductive technology, sleep learning, psychological manipulation, and classical conditioning. These all techniques were perfected in that state, and that eventually all those things actually, rather than an utopian society, it ended up in a dystopian society. So what happens? Read these bullet points. A future utopian state where citizens are produced in vitro. The society is structured in an intelligence-based social order where everybody is healthy and happy. Everybody is happy. immersed in soma, the soma we know, everyone gets to fulfill his or her desire. People no longer need to struggle, aspire, or feel emotions, or must make difficult moral choices. There is no issues. You simply enjoy your life. So that is the kind of state, utopia that has been imagined and created. But by how? By applying technology, manipulative technology, psychological manipulation. So in that story, in that brave new world, only one person fought against the state, and he is the the hero of that novel, and he kind of fought this this state, that this is not what a human society should be like. Atlas actually followed up this brave new world by two of his later creations, but he never changed his mind. And the latest one in this kind of theme, that what future might hold if we are not careful, is the non-fiction called Homo Deus, and written by Hariri. He's an Israeli kind of a professor, philosopher. So he kind of asking this question in the very end of his non-fiction, that what will happen to society, politics, and daily life when non-conscious but highly intelligent algorithms know us better than we know ourselves. So artificial intelligence, they don't have consciousness, they don't have a heart, but they would be manipulating us. That is the kind of a prospect. And how those, it's not just the artificial intelligence, but a superior race would emerge. Let me read this bullet point. In this provocative sequel to Sapiens, Sapiens is another non-fiction written few years before. Author Hariri raises the prospect of a small number of elites who elevate themselves to a godlike species called Homo Deus and exclusively derive benefit from technology in a new world order where they reign supreme in collaboration with artificial intelligence and super intelligent robot. And what happened to the masses? Masses were left behind to language, to just work. So this is the prospect. Okay, so argument. The proponent of eugenics says that we are morally obligated. They are coming from a philosophical basis that is called consequentialism, that whatever we do, we should be guided by its consequence. If something is going to be good, then it doesn't matter. If consequence is going to be good, I am allowed to do that thing. So that is a philosophical premise. Right or wrong is a different question, but that is the premise argument based on consequentialism come from. This obligation would remain but they say, this proponent, that based on philosophical idea of consequentialism, we should be choosing our offspring, better offspring. But at the same breath, they say that I'm not going to force you. It is completely up to you. That is the philosophical basis of this argument. There is another philosophical strand or movement or kind of idea based on what we call deontology. Deontology philosophical view is essentially that it don't, what is the consequence, good or bad, doesn't matter. An act can be inherently good or an act can be inherently wrong. Killing a people is wrong. That is a deontological, basis. So people who argue against euthanasia, they would be coming from this platform, deontology, that killing is a wrong thing. It doesn't matter. Even, if my patient want to die, even if he is suffering from excruciating pain and he is never going to be cured, but even then, even with his permission, I cannot kill him. So that is the idea, that is the basis of those who are against euthanasia. Again, we'll examine whether that is the right stand or not. But I'm laying the arguments out here. The ideal of liberal eugenics is not the same as the brutal state-sponsored program of elimination of human being considered as imperfect based on pseudoscientific knowledge. So it is not that. It is non-coercive, has the best interest of the parent at its heart in empowering them to bring the best possible offspring to the world. And it is, if you think, it is not different from ordinary child rearing practices. Like I want my children go to the best school. I want my children to go to America to do his post-graduation. It is analogous. New eugenics is not asking us to do anything radically different. So if I can afford, if I can choose, if I can afford to go to a doctor and pre-select an embryo who is going to be fair, who is going to be, intelligent, very, good, whatever, we define good as, then I should be doing it. Just like I send my children to a good school. Can you see their point of view? They're coming from a premise. An International Bioethics Committee actually agrees to most of these arguments that there is nothing wrong. If we can prevent all the bads, but we are obligated here to prevent the consequence as well. What might, if I am countering, I am taking a stand against eugenics, then I have to be able to counter this argument. Here I am, or you are not taking a stand. We are simply, laying arguments from either side. So despite deontological objection, it is wrong to choose traits of offspring. So that is a deontological argument, that it is wrong. Interfering with nature is wrong. We should not be choosing the traits of our unborn children. Let it be what it is, black or white or, blind or deaf or whatever. It's a gift of God. So that is deontological argument. Obviously, eugenics stand is different. They are arguing from consequentialism. So at present, reproductive technologies such as PGD, that is pre-implantation genetic diagnosis, is actually allowed. But it is allowed for serious Mendelian disease. If my child is going to suffer from a monogenetic disease, which we call Mendelian disease, then it is permissible that I can pre-select and not implant that embryo. But this is not for enhancing, selecting positive, so-called positive traits. It is not allowed in any society at the moment. PCD is only allowed, that is law, that's a legal matter, that is law, that is the law of the land in many places. So it is not allowed. But we are discussing here a bit hypothetically that what if, we are allowed to pre-select positive traits, which is not the case right now, which is a matter of debate. That's what we are doing at the moment. So counter arguments. So in ethics, the proponent has laid certain arguments that this is good, we should be doing that. Now I am now looking at the counter argument. So counter arguments is one of the arguments, one of the method you can argue, which is called slippery slope argument. So what the slippery slope argument is? PCD discriminates against disabled people. You see, not at the moment. We are talking about future, when anybody can do anything with the embryos. Any embryo I can select. At the moment, I cannot. Nowhere in the world you can select a baby using PCD in terms of positive traits. We can't. We can only select out embryos with Mendelian diseases. But this is hypothetical in future. So if we are able to do that, obviously we are not going to, choose for a blind embryo. We are not going to be choosing a deaf embryo. So then essentially what happens as a counter argument, what I am saying, that it sounds very good, but what that you are actually discriminating against disabled people, and you actually you are actually not helping the parents, you are actually putting the parents in a dilemma. So you are actually not expanding the choice of the parents. You are actually morally obligating the parents to take a certain direction. What is choice? Choice is any path that I would like to take. I got alternatives. There are 2 paths, 3 paths. I want to take whatever path I chose to. But actually, are you allowing that choice to the parents? Because you are making such an argument, making things so easy that parents got no alternative but to choose positive traits, and discriminate against an embryo that might be, born deaf or, dumb. So essentially, the prospect of creating designer children inspired by eugenic logic raises fundamental ethical question. Liberal eugenics may well be based on individual choice and not coercive, but the consequence is not going to be so different to that of the old eugenics. Yes, old eugenics was very crude, blunt state force, but new eugenics is very subtle. We are not applying any blunt force, but result is not going to be any different. So it is like a slippery slope. If we allow that, then it is going to be the same as the old, consequence is going to be the same as the old eugenics. So it is not fundamentally different. So this argument is based on slippery slope argument, that if I allow this new thing to happen, the possibility is that then my standard would be relaxed, and I would, based on that first relaxation, I would start enjoying the next bit of a relaxation, which is not so different from the first relaxation. So I can always argue, oh, this is allowed, so this is not so different. I'm doing this essentially the same thing. So you are on a path, on a slippery slope path, then you will end up doing very bad things. In the end of the slippery path, you will be doing certain things that are actually not intended by the first relaxation. So that is the slippery path argument. But philosophically, slippery path argument is not a very sound argument. We will see why. But this is the slippery path argument against new eugenics. And like I said, at present, ethical consensus for intervention like CRISPR is only to modify an existing person to cure diseases, like pre-selecting embryos. PZD, a similar technology or rather advanced technology is CRISPR. With PZD, what we do, we cannot cure the disease. We simply eliminate that embryo. We don't implant that embryo. But with CRISPR, we can actually mend that embryo. We can correct that disease. So that is allowed. That is in many societies, many countries, we can now apply CRISPR technology to cure a genetic disease in the embryo. So that sounds like a very good thing, and that is allowed as well. But CRISPR, PZD probably is not that radical. PZD probably cannot do that, but CRISPR really can actually facilitate, to enhance human being. We can actually edit a gene, make it better. We think it is going to be better. There is no experiment, there is no evidence base as yet, but theoretically it is positive. We can probably, you have heard about, I think 1 or 2 years back in China, a researcher, he came up, he actually produced CRISPR edited babies, and those babies are going to be immune to HIV/AIDS. So that is a genetic enhancement. This is not allowed anywhere in the country by law, but he did that. So that is kind of like a slippery path. You can see how things can go, from one step to, if we liberalize CRISPR for this purpose, then it is easy to slip to the next application. So that's the slippery slope argument. But what is wrong then? if we enhance the baby, what is inherently wrong about it? So the wrong is coming from this particular argument of human dignity. And it says the human genome is the heritage of humanity. Any modification should be allowed only for preventative, diagnostic, and therapeutic reasons, and not for propagating into descendant. You see, it should not be germline editing. If I am a CRISPR-edited man, so far my somatic genes are edited, and that's okay. But to my offspring, I should not be passing on my edited genes. You know, that is the stand currently, the worldwide consensus, that human genome is a heritage. We cannot contaminate this human genome. We cannot play with human genome. Yes, we can edit it to cure a disease, but we cannot possibly be, allow these edited cells to be passed down the line. So we cannot edit germline, information essentially. And Universal Declaration of Human Genome and Human Rights states the human genome underlines the fundamental unity of all members of the human family, as well as the recognition of their inherent dignity and diversity. So that is the stand at the moment. So I'm kind of mixing argument and counter argument. So I'm now listing another set of counter argument against eugenics. So it's very, actually, as I said, I'm not an expert, so slides are a little bit haphazard, but I hope you can see, you can see the good points, and at the same time, you can see the bad points. So you have to form your own opinion. So that is about, argument. So the critique of new eugenics, they are listing a few more points here. The human enhancement impinges on the principle of respect for human dignity and runs against the ethics of humanity, ethics of equality of every human being, irrespective of their abilities. So this is a fundamental value, universal value. It might change tomorrow, but as on today, this is what we agree on as a human race. Even if not endowed with the attributes considered superior by liberal eugenics. Whatever bad things we have, it is part of humanity. This is who we are. If we select only the good, think about Aldous Huxley's that future state. Everybody is happy, but still people are not. Eventually they found out that they are not there. They are reduced to bunch of chickens, produced in a hatchery. Are we happy to live in a society like that, where everybody is the same? Yes, that Aldous Huxley's novel Society is categorized into few, but that was deliberate. Deliberately, we are producing very best, second best, third best, and the worst. But think about that. Everybody is good. Even that kind of society would be attractive to us human. We do not want to be like, we want art to be art. We don't want art to be heaven, actually. Essentially, that's what we are saying. There is a new tendency. This is a very strong argument. There is a new tendency to relink quantitative measurement to deterministic understanding of superior genetic traits. What it essentially means, as if there is a gene for IQ, intelligent quotients, that this gene A, if you got that, you would be a person with very high IQ. But this is not science. As yet, we don't know. We have identified few genes we know for sure that this gene causes this Mendelian disease. But for many complex traits, a trait like intelligence, which is so complex, we cannot possibly say that one particular gene is responsible for intelligence. So that would be a very dangerous thing if we allow it to propagate. That racism would come back. Racial. There is a group of people who are working towards that. That's a revival of the akin to revival of the race science. Many turn out to be an instrument of causing greater social, and many of these things would be actually instrument of causing social injustice. But then the counter argument, then again defense comes into play. We need new technologies and equitable access to these to reduce inequality. So proponent of eugenics would now say that no, actually you are talking about inequality, but actually we do need new technology to reduce inequality. You know, your slippery slope argument is wrong. We can put law in place and we can prevent slippery slope. You know, we'll be using CRISPR, we'll be using PGD for whatever purpose we have set out, to be. Your slippery argument, that doesn't hold water. So that's what they are saying. It is not necessary to, but they are making another concession that we are not invoking moral imperative argument either. It would be totally free. The parents should be simply allowed to enhance their offspring, just as they are allowed to choose everything else at the best interest of the children. So there is some repetition you can see in the slides. But now we are questioning, is it a genuine choice? Actually, I alluded to this as well. Francis Fukuyama, he's a USA, US citizen and a very renowned philosopher of our time. In his book, this is the book, Our Post-Human Future. He has speculated, he has written about this possibility. So he has raised his apprehension that scenario where wealthy routinely use PGD, which may even allow one even to predict the social background of a young person by his or her looks and intelligence. You know, rich should be doing that routinely, poor obviously would not be able to do that. If someone doesn't do as good, or he or she is able to blame bad genetics choice made by his parents rather than his own or her own labor and effort. Eventually, adoption of reproductive technology as they become efficient, safe, and commonplace would eventually be dictated by the market force, rather than any ideology. Parents should be forced to choose to enhance, as refusal would jeopardize the prospect of their offspring in an increasingly competitive world. So you see, it is not genuine choice. I already made that point. All the libertarian people who says that we are not doing anything different, we are giving you choices, but you can see that these are not genuine choice. Only choice is that I have to adopt this technology, otherwise future of my children is doomed. So that is not a genuine choice. But look, this is not one-sided. He still, Fukuyama is still not saying that we should not be doing that. He's not arguing. You see, this is ethics. To arrive at an ethical decision, we need to consider the possibilities. We may agree with it, we may not agree with it, we may find a better solution, but we are obligated to consider the pros and cons. That is ethics. So Fukuyama, he strongly argues against a defeatist attitude. He suggests an advocate using the power of the state to regulate technology. Although it would be challenging to find common ground at an international level, as countries and societies differ in its attitude towards underlying ethical issues. But he disagrees with the notion that it is impossible to do so, arguing that some do get away with heinous crimes from time to time, but that is not a reason to legalize crime. You see, if we say what his counter argument is, yes, there is a possibility that some people in the society are criminal, so therefore decriminalize, make that there is no crime, because having that rule that this is a crime is not working, because there are many people in the society are criminal. We do not buy that argument. So he's giving that, this is what ethics is. You bring up a analogy with another situation and try to argue your point. So Fukuyama is saying, he's bringing up either side of the story, that yes, PGD, CRISPR, it is fraught with immense risk. It is a good thing to be able to cure genetic diseases, but it is a slippery slope. Some unscrupulous people may use it for different purpose, and parents would be left with no choices actually but to pay money to the doctors and get embryos pre-selected. It would not remain as a choice. These are all possibilities. But just because these are bad possibilities, should we abandon the good that it can deliver? So that is what it is about, But fundamentally, to summarize, whether editing our germline DNA is a good thing or bad thing, I think at the moment, our societal values, ethics is based on our values. It is not about the possibilities, this thing, that thing. What is our current values? As of now, as a humanity, we consider our genome as an integral whole, and we do not want it to be manipulated with. It is okay to edit it to cure a disease in me or in you, but it should not be edited in such a way that edited traits are passed down the generation. So that is a value. It may change tomorrow, fair enough, but that is what it is. So I think I laid arguments and counter arguments. I am not giving my preference because that is immaterial. I think we all need to think, and I hope you got an idea about eugenics, what are arguments and counter arguments. So let me quickly move on to the euthanasia argument. So what is euthanasia? It is very simple. It is killing a patient for the patient's benefit. It is a form of assisted dying. So I kill somebody. I think it is for his benefit. He is suffering immensely. This life is not worth living. So let me kill him. That is euthanasia. And it is permissible in Belgium, Netherlands, and Switzerland. And in USA, not euthanasia, I think in few states, what is permissible is assisted suicide. It doesn't go to the killing, but I as a patient decide that my life is not worth living. I'm not going to be cured. I'm suffering immensely. So I want to die, but the state doesn't, the doctor is not allowed to kill me. It is against law. So I will die, I will commit suicide. You just help me. I'm not asking anything more. Just help me to die. So that is called assisted suicide. And there is another form of sort of allowing people to die. It is not killing. It is withholding or withdrawing of life-extending medical treatment. I am not dealing with this today, but I think this is a practical topic for all of us in India. We put people through immense misery. We do not respect the patient will. We just decide, oh, he needs to go onto the ventilator. I would give him this chemotherapy. I would do this thing, that thing. We do not explain things to patient. We are not following any of the principles. The 4 principles that I outlined, that patients wish his best interest, but we still give life-prolonging treatment. Life-prolonging meaning what? Not indefinitely, for days, maybe for weeks. And let me tell you, every Western countries, withholding and withdrawing life-extending medical treatment is permissible. In UK, here, we practice that every day. But again, there are risks in there. You have to have strong regulations, strong ethical guidelines. But we are not discussing this point today. We are discussing only euthanasia. So let me clarify the definitions. In the very first few slides, I said that definitions needs to be clarified. So euthanasia, what is euthanasia? X performs an action that intentionally kills Y for Y's benefit. Yeah, so that is euthanasia. But now let us consider what is voluntary and non-voluntary and involuntary euthanasia. Voluntary euthanasia is why competently request, the patient request, he is in conscious, he knows what he is doing, so he is competent to make a decision for him. So he is saying that kill me because this is the last few days of my life, and so please doctor give me this little injection. Yeah, that is called non-voluntary euthanasia. Y is competent to express a preference regarding the action which result in Y's death. And involuntary is X performs euthanasia despite the fact that to the contrary of Y's expressed wishes. So involuntary euthanasia we cannot perform. Nowhere it is permissible. Not in Netherlands, not in Belgium. Because I don't want to die. You know, maybe I know, but I'm not allowing you to kill me. So that is completely out of question. We are not discussing involuntary euthanasia. So we are discussing voluntary. So I am confusing voluntary and non-voluntary. Voluntary euthanasia is that I request, I am competent, but non-voluntary euthanasia I got slightly wrong in the slide. Sorry, not actually, I read it wrong. In non-voluntary, is not competent to express. Yeah, maybe he's unconscious. He's a children. He's a person who cannot express. Maybe he got dementia. Yeah, I decide as a doctor that it is in interest to die. That is non-voluntary. It is not that I am saying don't kill me. Simply, I cannot give my consent. I am not conscious. I am dementic, whatever. But voluntary euthanasia is I am competent, and I am asking my doctor, please, doctor, kill me because my life is not worth living. I am suffering from immense pain, and there is no prospect that my disease is going to be cured. So I can request that in those countries in certain limited conditions. Not I am a healthy person today. I cannot decide, oh, I want to die, doctor. I want to undergo euthanasia. No, that is not the situation. I can request euthanasia. I can request euthanasia in very specific conditions. I got incurable disease. Disease is rapidly advancing. I am suffering from immense pain. My life is ending anyway. So please, doctor, I am competent. I know what I am saying. Please kill me. That is voluntary euthanasia. And we are talking about voluntary euthanasia today, not the other form of euthanasia. And withdrawing treatment, withholding treatment is, as you and I all know, X allows Y to die by withholding life-prolonging treatment. Yeah, this may be because X believes that withholding treatment is for Y's benefit, or because Y completely refuses the treatment. So withholding treatment, you see, if you go to the principles, I can say, I know I'm dying, but I am not, don't give me that injection. Don't take me to the theater. I'm not giving permission. Yeah, so it could be because of that, or as a doctor, you decided in my best interest that I'm not going to give you that drip. It is meaningless. That is withholding treatment, prolonging life by artificial means. And withdrawing is slightly different. The patient is already on a specific treatment. I am withdrawing it. That is withdrawing treatment. That's the active decision. Whereas withholding could be a passive decision. So there is a bit of difference, but both withholding treatment and withdrawing treatment are permissible in country like United Kingdom. Obviously, suicide, it's illegal. Assisted suicide, as I said, legal in certain states in America in certain conditions. So these are the different kind of definitions. But we are talking here about voluntary euthanasia. But you see, you can immediately see as a doctor, this is a deontological argument. Thou shalt not kill. This is one of our principles, one of our most venerated principles, moral principles. On the other hand, to most regarded principles guiding medical practice requires doctor to practice euthanasia. Respect for patient autonomy. If patient asks me, doctor, you cannot cure me, but at least you can kill me, you can relieve me of my agony. And promoting patient best interest. There are situations when it is really in the best interest for him to die. You see, there is a conflict there. So what is best interest? If a patient with incurable and fatal disease may reach a stage where will die within a day or two, but could be kept alive with active treatment for a few more weeks. Most agree it may be in best interest of the patient to die, particularly if suffering. So this is a general agreement, but law doesn't permit it. So this is what not everyone, law doesn't permit, it's a different thing, but even within our community, not everyone agrees. It's a philosophical argument. Can it be in best interest of a patient to die? So we are assuming dying is a very bad thing. So where on earth can there be any condition where it is better to die than to remain alive even for an hour? So that is an argument. So counter arguments are killing may cause the patient more suffering. So those who are against euthanasia, they argue these points. The process of killing, may be more suffering. It may cause more suffering actually. That's probably wrong, but that's what they argue. However slim, there is a chance that patient might recover. You have decided that this patient got no future, he's not going to survive, but who knows? He just might get lucky. Then it is unfair to put the doctor in a situation to make him kill. You see, I'm a religious person. I happen to be a doctor, but for me, killing is just, I do not kill. That is my moral stand. So if as a profession we legalize euthanasia, then I cannot refuse that. I have to kill, and then for the rest of my life I would suffer from a feelings of guilty. So it is like unfair to put the doctor. That's what they are arguing. But these are flimsy arguments, as you can see. Once legalized and fail to adhere to that killing is wrong. Soon doctor will be killing patients under mistaken belief that it is in patient best interest. You see, it is a slippery slope argument. You have legalized it. Yes, many a times I will get it right. It is in best interest to kill this patient, but I may get it wrong. And maybe some very immoral people amongst us may actually, go on a killing spree. Here in the UK, even without euthanasia, we know Harold Shipman case, 20 years back, some of you may remember that nowadays we go our revalidation, our medic practice fitness to practice certificate is revalidated every 5 years. And that came from Harold Shipman case because he went on killing elderly people in the belief that it is in their best interest to die. So he was practicing kind of involuntary euthanasia. And since then, we every doctor in the UK, we are closely monitored, and our license is valid only for 5 years. Every year, we have to undergo what is called appraisal process, and after 5 years, GMC considers 5 appraisals and decide whether we are still fit to practice medicine. So that is a draconian, but it is happening. It is there now. Then killing is it is like interfering with nature. So that is another argument that we are playing God by practicing euthanasia. So we should not be practicing God. So these are the arguments, practicing God. Oh, I can say there are 2 more arguments there. This is the problem of presenting in this mode. There are 2 more arguments there, but arguing from nature, that this is going against the nature. So let me now go to the next slide to actually counter those arguments. The number 1, what was the number 1 argument? That killing may cause patient more suffering. So this is countered by, it is not an argument against euthanasia. It is not a fundamentally argument. We are not saying by this argument that euthanasia is wrong. we are citing a practical difficulty. That is what that argument is about. If uncertainty was the reason not to act, we either would be completely paralyzed in making decisions in many aspects of our life. If we just, put a spanner, in the cycle, in the wheel, it is like putting a spanner, not allowing life to go on. Oh, don't do that because there is a possibility that, this would do that. So that's not an argument. So number two argument was what? However slim, there is a chance that patient might recover. That is not true. From your science, know from your evidence based that a dying patient, a terminal patient, there is no miracle that he would survive. Those are the cases you are practicing euthanasia anyway. So that's not an argument. Then it is unfair to put the doctor in a situation as if, again, it is not argument against euthanasia, but you are becoming empathic to the doctor, trying to argue your case. Oh, it means that putting the doctor in a difficult position. But the doctor would not feel guilty because he was not doing anything wrong. He was doing anything wrong, but because euthanasia is not wrong, so doctors should not be feeling guilty in a situation where euthanasia is. Then I spoke many times that slippery slope argument is usually fallacious. That is not a good argument, because to argue from slippery slope point of view, we have to be able to demonstrate that there would indeed be a slippery slope. It cannot be regulated. So you have to produce empirical evidence that if I allow this, then this is what is going to happen, because that is our past experience. This is, you have to argue from experience, not from theoretical basis. Theoretical slippery slope argument is fallacious, but from practical point of view, we can still argue that point, that euthanasia in the UK, actually euthanasia is not permitted on that ground that there would be a slippery slope. It would be practiced wrongly, and the law would not be able to regulate it. The system would not be able to regulate it. A lot of people would be pressurized. Actually, old people would be pressurized to accept, to give permission for euthanasia. So it would be actually involuntary euthanasia, but people would be, made to sign or whatever. So there is a fear that it might lead to a, it would lead to a slippery slope. But again, it's right or wrong, we don't know. But in many countries, I think because of the slippery slope concern, euthanasia is not allowed. And the argument that it is not natural doesn't hold water either, because what is unnatural is not clear. Even if it is unnatural, it does not follow that it is morally wrong. And medical practice itself is unnatural, isn't it? If we allow nature to take course, then we should not be treating any patient anyway, because that is interfering with nature. So that argument doesn't hold water. Then I think next argument suffers from the same weakness, providing IVF. Oh, that is the argument that we should not be doing any artificial thing, but that is similar to going against the nature argument. But if killing somebody by if killing is artificial, then IVF is artificial. Putting somebody on ventilator is artificial. So everything we do is artificial. So that argument doesn't hold water either. So actually the very last argument, which is the deontological argument, that killing is bad. We should not kill people. That is the strongest argument against euthanasia. Because that goes against our principle as well, that don't do harm. But now it's a value matter, isn't it? I mean, is killing always a wrong? If you take a standpoint, it is always a wrong, I cannot argue with you. So it would be up to the society. Is killing always wrong? So it is a value thing. It would differ from society to society. So this is about euthanasia. I think this has been very long. So let me quickly move on to the next issue, and then I will take some questions. As you can see, that these are difficult, and you do really need expert philosopher to help you with ethical decision. And you would be surprised, in America, I think the practice is now growing up, that doctor can actually, an ethicist, medical ethicist can be actually on call. So there are ethicists on call. If you're faced with an ethical dilemma, you can actually, like you call a microbiologist in the UK for antibiotic advice, you can call a medical ethicist. That what shall I do? Because ethical issues are so common, particularly with dementic, people with dementia who cannot give consent, who do not know what is in their best interest, but they may have some wish from their previous, we know about their wish from their previous, when they were normal. So as a doctor, then I have to balance his previous wish with his current state. So I think dementia is increasing in our society. I really suggest that there is an ethical, session on dementia. And the other one is obviously withdrawing and withholding treatment. These two are very practical issues that I think this forum can deliberate later. But let me come up with this non-identity problem. This is again philosophically so complex that I think I understood the issue, but I don't know whether I will be able to make you understand. This is quite complicated, but let me try. So few slides, nothing, not very, and there are examples, so it would be relatively easy to understand the argument. It is actually coming from this Human Fertilization and Embryology Act, that PGD, that pre-genetic diagnosis of embryos is now possible. It is permissible in many countries, and it is allowed. So that brings certain ethical dilemma for doctor. So let me go through. So this fertilization particular act in the UK and many countries, it would be the same if they got an act. It imposes a duty on the fertility clinic or on the doctor to consider the welfare of any child who may be born as a result of the treatment, including the need for that child for supporting parenting. So if I am providing IVF treatment in the UK, I am obliged to consider the child who is going to be born actually can lead a good life. He got good parenting. It doesn't say mother and father because here, this is no longer necessary. There may be two fathers, this is allowed in the country like UK. So you can get a baby through IVF, but there need not necessarily be mother and father. It could be simply parent. Both can belong to the same sex. So that's why rather than father and mother, the new revision used the word parenting. But essentially, it is imposing a duty to consider that if the baby's life is not going to be good, then I probably should refuse IVF, But that raises philosophical question. Concerns for the welfare of the potential children rules out fertility treatment for an elderly woman. It's a real case. I think suppose a 60 years old come to your clinic seeking fertility treatment. You know that a baby born to a 60 years old lady would be ridiculed in the school gate by the society. His life would be miserable. I possibly cannot give you the IVF treatment. As a doctor, you can take that stand. Very philosophical, this is ethical dilemma. We'll consider those dilemma. So this is called, in philosophy, this is called non-identity problem. That is the problem dealing with somebody who doesn't exist today. That's why I call non-identity, a non-identifiable person. So it's called, in philosophy, it calls non-identity problem. So let me read these through bullet points. The non-identity problem raises questions regarding the obligations we think we have in respect to people who, by our own act, are caused both to exist and to have existence that are, though worth having, unavoidably flawed existence. So let me explain. So this problem arises when, as a doctor, I can help somebody to come to this world, but he may not be a fully, he would have some defects. Although his life would be worth living, because generally speaking, life is worth living, but his life may not be that enjoyable. That is the issue here we are grappling with. I can help this lady. A child would be born. He would be born deaf. His life would be worth living. A blind person's life is worth living. Physically challenged people's life is worth living. As a society, that is our value. We cannot say that he is physically challenged, his life is not worth living. But we know, that life would be a limited life. So what is my ethical duty? Shall I help to bring the child come to the world or not? That is the crux of this, issue here, the non-identity problem. If a person's existence is unavoidably flawed, then the agent's only alternative is to bring no one into existence at all, or to bring a different person, a non-identical but a better off person into existence. You see, you will see the example. It's very interesting. So if somebody who is, because I am a fertility doctor and a child is going to be, coming deaf, what is my alternative? My alternative is to not to bring that person to this world at all. So abort that, throw away that, that embryo and just not allow him to come to this world at all. Or we can help the lady to select a different embryo, a perfect embryo. So I am bringing in a different person. Try to understand this. By helping this lady, because there are 4 embryos, 3 are diseased. Disease meaning the embryo's got some kind of what we consider as a flaw, but the 4th embryo is perfectly healthy. So if we don't select any of those 3 embryos that we think as flawed, we are choosing the 4th one. He's a different person. It is not the one that you have kind of comparing with. He's a completely new person. So remember that thing. If the existence is worth having and no one else's interests are at stake, it is unclear on what ground of morality I would insist that a choice to bring the one person into flawed existence is morally wrong. So you see, the embryo, if I don't choose the embryo with deafness, I am choosing the embryo with no deafness, but the parent's preference is to go for the deaf embryo. How I can deny that? You see, because if I don't go by parent wish, then I'm actually denying somebody's life, and the other embryo, if I choose, I'm bringing completely in a different person. So this is what this is saying. If the existence, because a deaf person's life is worth living, it is not that it is not worth living. So if I am bringing him in, I'm not harming anybody. So what ground then morally it is wrong to bring that person in? Because if I bring him in, I'm not harming anybody else, have I? Because if I choose a different embryo, that is a different person. That is not the completely different. Every embryo is a different person. Okay, let me go to the next point. And yet at the same time, you see, intuitively though, it seems in some cases such choice is clearly a wrong moral choice. So some instances it could be clearly wrong. So these are the non-identity problems. Let me now come up with the examples. Really interesting. So read this hypothetical case. A couple with genetic condition of deafness wish to have a deaf child, so that the child is a part of the deaf community. You know, these deaf people, dumb people, handicapped people, they really value their life. You know, they enjoy their life. For me, I pity a deaf person, but a deaf person doesn't pity himself. For him, he is completely a normal person. So likewise, a deaf couple, they want their children to be deaf. Nothing wrong in that choice. So the lady become pregnant with, now the ethical dilemma for you and I. The lady become pregnant with a fetus who does not have the gene causing deafness. So this baby is a normal baby. Yeah, but now suppose there is a drug, a medicine available that can make a fetus deaf, but no other side effect. That drug would only make the fetus deaf, but no other side effect. The couple decide that the woman should take the drug in order to ensure the children is born deaf. Now the couple, husband and wife, now decided for themselves, doctor, my embryo is completely normal. I am going to have a normal baby, but I don't want what you call a normal baby. I want a deaf baby. And you got this medicine. Prescribe that so that my baby is born deaf. So now, would the couple be morally wrong? First, I am asking, is the couple is morally wrong? Would a doctor be wrong to prescribe? And then, would the child, such born deaf, have a moral legitimate grievance against the parents and or the doctor? What is your answer? Think about that. Okay, the next hypothetical case. It is the same case. A number of embryos created by IVF to the same couple and tested to see which have the deafness gene. So A is normal, B has the deafness gene. The couple's preference is for the embryo B because B got the deafness gene. So again, the same question, are the couple morally wrong? Would the doctor be acting wrongly to agree to their decision? Does the child have a moral legitimate grievance against the parent or the doctor? So the child such born, would he have a legitimate grievance? Okay, now consider this case. A 35-year-old woman delays pregnancy for years, knowing fully well that she is going to conceive a child with trisomy 21. Because we know if we delay pregnancy, that's a very, very big possibility of having a child at 40 years old age. She asked for a prescription for contraceptive pills and the doctor prescribed the pill. After this, the woman became pregnant after so many years and the child, as we kind of anticipated, is born with trisomy 21. So did the doctor's act harm the child? That is a question, very specific question. That the fact that I prescribe contraceptive, is that the cause of this trisomy 1? Yeah, that is hypothetical case 3. The next one, there is the acne we know is a trivial condition, but for some people it could be really, really a nasty condition, and it could even lead to facial disfigurement. So a lady with severe acne got every right. Acne could cause a lot of mental issues as well, psychological issues. So a patient, got every right actually to whatever medicine is available to be prescribed. And isotretinoin, I cannot even pronounce, isotretinoin, those in dermatology would know, is a medicine that you can prescribe to treat acne, but it causes severe congenital malformations, mainly facial appearance and heart. So now, this is a case. Is it wrong to prescribe the drug in pregnancy? The answer is really yes. It is. As a doctor, you would not prescribe if somebody is pregnant. You would generally avoid anything that might be detrimental to the fetus. But look, consider this case. But if the woman is not pregnant, but might become pregnant while taking the drug, what the doctor should do? Here the doctor can, what doctor can do, doctor can say that delay your pregnancy, so far you are taking this medicine. So I am prescribing you contraceptive, so delay your pregnancy. It's a good practical solution. But if you cannot rely on that woman, that this woman is not reliable, she might become pregnant tomorrow. Because I know her, she would not be taking medicine, contraceptive, and she would do anything, could do anything. That is the situation you are faced with. Yeah, then what you do? If she does not delay the child is born with abnormality, and child is obviously harmed. She went on to become pregnant while on the medicine. It's slightly different from she is not already pregnant. She was not pregnant when you prescribed. And if she does delay, she has, here actually answer is already given. If she doesn't delay, she hasn't harmed the child. But, if she doesn't delay, if she does delay, okay, now we are coming, I'm not, the answer is there. So I'm asking you, so if she goes on to give birth, become pregnant, because she didn't listen to doctor's advice, she took the drug for acne, but at the same time, she went on to become pregnant, and a child is born. So did she actually did harm to the child? That is the question. Yeah. So it is very interesting. I think many of you, I mean, I in the first instance when went through these cases, I thought it's really, really bad. I cannot allow a deaf children to be born. I cannot be part of that process. That's the intuition. We come up with that. That's a bad thing. But look at the let us go through these points. It can be argued that it would be better if the decisions were made that would lead to the birth of whichever child would be likely to have a better life. That argument comes from maximizing overall welfare. When possible, that is the right course to pursue. But here, this doesn't apply, because the woman is adamant. I want a deaf child. Yeah, if kind of we are in agreement, it's a we can reason that everybody is in agreement. Okay, I delayed a pregnancy. Let us go. Everything is by consensus. Then you are not facing any dilemma. In the first example, woman is insistent. I want the embryo that got the deafness. So you cannot, that is the situation. In none of the cases, therefore, however, can an argument be based on the interest of the potential child. We cannot say, I cannot allow this embryo to be implanted and a baby to be born with deafness, because that would meaning I have caused harm to this baby. That argument is flawed. Because, as I alluded to, if you choose a different embryo, you are choosing a different person. So this deaf baby who is coming to the world, he would be grateful that I saw the, I am born, because we consider life as a good thing in general, unless it is so bad that it is not worth living. But in society, we have already agreed a blind man's life is worth living. A deaf man's life is worth living. So that this child has been brought to the world, he would not have any grievances against anybody. Because if parent made the choice for the other embryo, this deaf child would not have been born. Do you understand the issue here? So you are legitimately, we are okay to go by the choice of the children, choice of the woman. So similarly, if prescribing a drug that may harm the fetus, that is obviously wrong because you are harming a tangible thing, you know, a fetus. But if it is not that child is not born yet, you are only, you know, delaying pregnancy, then if you delay pregnancy compared to who would have been born today, compared to who born 5 years down the line, is a different person. So in the third example, the trisomy 21, that the lady delayed pregnancy and I was helping her to do that by prescribing medicine, I was not wrong. I was honoring the lady's decision. And the child who born with trisomy 21, he got no complaint either. Because if the lady given birth to somebody earlier in her, you know, when she was young, he would have been a different person, not this person with trisomy 21. So these are separate individuals. You see, this is slightly difficult to get your head around, but this is called non-identity problem, and it is actually applicable to other situations in life as well. Okay, let me read through the rest of the points. But what if the doctor's action may lead to the child being born disabled, and there is no child who has been made worse off? I think that's what I have actually explained. So basically,
excuse me, sir, but we cannot hear you. I mean, something's wrong with the sound again.
Oh. Can you hear me now?
Yes, now it's.
Can you hear me now?
Yes, yes. Please go on.
I don't know what went wrong. Yeah, so let me summarize essentially the ethical position here. In societies that value patient autonomy and reproductive choice, doctors should not normally override a woman's choice in situations where no person is harmed. Yeah, unless the child's life overall is not worth living. So we already, as a society, we value reproductive autonomy, you know, patient's choice. So then as a doctor, I have got no moral issue actually allowing that diff embryo to be selected, because I am not harming anybody. If I choose another embryo, actually it's a different person, and I'm actually preventing existence of a person, you know, because no life is not worth living. So I'm actually preventing the diff child coming to the world. So that might be actually morally wrong. So the conclusion, actually, in these cases, in non-identity problem, goes against our normal intuition. So only argument we can make is from the argument of maximizing welfare. You know, that in general, people, you know, we should be doing, you know, why a diff child? Why not a normal child? You know, that is the argument from maximizing overall welfare, but not from the point of view that you have harmed somebody. Because you have chosen a different embryo, that's a different person. If you have chosen a different timing, it would still be a different person. So I hope I managed to, you know, kind of, you know, get this point across. And I think this is my last slide. So essentially, I think it has been almost 1.5 hours, and I have dealt with 3 ethical issues, which are probably not of immediate relevance to you, but hopefully you would find resonance that these are real issues we would be confronted with, and you got some food for thought. And as I said, ethics is about argument, and there are techniques of arguing from principles, arguing from logic, giving logic, then countering that logic with counter argument, then again another set of counter arguments. You know, you then come to a conclusion. But essentially, it is the values. It is not the facts. Facts and values are different. Values can take precedence when we take an ethical decision. And values could be different from one context to another, and one situation to another. We have to be aware of that. And rationality and logic, yes, foundation of whatever we do, but we have to apply our heart as well, heart and mind, and we have to be wise, we have to be creative, we have to be imaginative in finding solution. So that is my summary. I hope with my limitation, I have been able to, make few points. And now if there is any question, hopefully I would try to, address those questions. Thank you. Thank you very much.
And so tactfully. Yes, it was. So thank you very much, Dr. Jayanta Biswa Sarma, sir, for that brilliant and all-encompassing deliberation on ethics, and so tactfully percolating it down to our daily lives, to bureaucracy, to politics, etc., etc. So what we heard hard about your lecture is that ethics and ethical dilemmas are a part of our everyday lives, and it is only a matter of awareness to solve the issues. And it is important to know the technicalities, how to implement them. And number two, a good amount of the so-called abstract conscience is required to formulate ethical principles. These are in a lighter vein what we have observed from your lecture. And we are happy to inform you that, sir, the number of participants for this lecture exceeded the limit, and this indicates the thirst for new knowledge in our people. And probably a speaker of your magnitude is needed to quench that thirst. Thank you so much. Once again, I invite all our participants to interact. If you have any questions, kindly ask them. And our speaker, as he has said, he'll be very happy to answer those. I request.
You can ask slightly different issues as well. It doesn't matter, we can discuss a few things, but I'm not in a hurry. But it has been a good experience for me to interact with you, be a participant in this very first lecture of this series. I cannot come out of this.
Yes, Twinkle Saikya, would you like to ask something? I can see a raised hand there.
Dr. Manshi.
Yes, yes.
I am Dr. Ramen Laludar from
yes,
Borpeta Medical. Yeah, from Borpeta Medical College. I am attending. Hello.
Yes, am we I can hear you.
Yes, Srimanta.
So I am joining with my team. Along with me, HOD, medicine, surgery, radiology, ENT, all are with me. And my students are also attending that way in the various medical colleges. First, I want to thank Dr. Jayanta for your effort being given from all the way from abroad, deliberating this sort of lectures for the benefit of staff and students. And of course, the overwhelming response of the listener. So, but Jayanta, I would like to request you that this was our effort being made since long. Like, see, in terms of evidence-based medical practice, in the context of state like Assam, there are many, maybe I'm criticizing the prescription or the practices, but with me, Dr. Paresh Sarma and Dr. Partho is there. They also pass their comment. So while we are prescribing or while we are advising any investigations, so that is why I would like to request you from this forum that when we arrange a talk, evidence-based medical practice, maintaining the ethics. So suppose someone is complaining, I'm a radiologist by profession, someone is complaining of headache. So whether I'm going directly for the CT scan, whether I'm placing the patient for MRI, or whether some other investigation to exclude sinusitis. So this is number one request. And number two, I would like to also thank Vice Chancellor Madam for arranging this sort of guest lectures for the benefit of not the medical colleges, doctors and students. Also, I have seen that from nursing practice and paramedical institutions, so they have joined. So I request you kindly, Madam, can we arrange a protocol-based practices? If a communication being made with the principal of the various medical colleges, so we can start with the protocol-based medical practices. Because in one patient suffering from fever, one doctor is prescribing some other antibiotic, the other is prescribing some other antibiotic. Most of the occasion it is being found that patients are coming from the private institution to medical colleges are presented with a resistant strain, MRSA strain, resistant. So this is my request. So now I would like to request Dr. Jayanta to speak on it, whether this is possible or not.
Yeah, Srimanta, you have raised practical issues. I mean, obviously, in the very beginning of my lecture, I said that today's topic is not about those kind of practical issues. We are discussing, in a way, in our context, it sounds a bit theoretical to discuss about euthanasia and and the non-identity issues and about CRISPR, implication of CRISPR technology. This is a flavor about medical ethics, but there are many practical issues. Even before we go to the nuances of thinking about ethics, we are actually practicing criminality. What Srimanta is saying is blatant unprofessionalism. If you prescribe something that is not in the best interest of the patient, if you are investigating something that is not in the best interest of the patient, it should be struck off from the register of the Indian Medical Council. As simple as that. So you have to make, that's why I found myself kind of what abstract topic I have picked up. When we are kind of, we should be discussing unprofessionalism amongst ourselves.
Because the students, Jayanta, because the students are here. So when we arrange for the benefit of students?
I'm coming. Of course, why not? I think, of course we can. Of course we can. You see that this is the dilemma for a university like Sankaradeva, medical university as well. You see, on one hand, we'd like to discuss about philosophical issues, the nuances, but we are advanced enough to even consider those nuances. You see? But these are so important. In any modern university would be discussing this kind of issues. At the same time, the practical issues that Srimanta has raised, those are the burning issues. I think university has to do both, maintain a balance and enforce professionalism. I think we need a lecture series on professionalism. Professionalism is different from applying ethics. Ethics are nuances. Only civilized people discuss about ethics. If I am uncivilized, I have to be reined in. Don't take commission. Don't prescribe MRI only because you are getting commission 40%. I'm not civilized. So for me, a different set of training is necessary, isn't it? So it is. So you have to deal with me with a different set of instruments. I think I take Srimanta's points. I think when our Sarma sir was vice chancellor, when this university was established, in the very first year, there was an online lecture, online e-learning platform was created, and I was sort of associated with that. In fact, I put all my effort there, but that was too early. Sometimes you have to do things at right time. And one of the topics of that e-learning platform was evidence-based medicine. It was a complete e-learning course, but I didn't find anybody taking up that course. It was not a mandatory course. Yeah. So and that was 10 years back. Only now we are used to this e-learning thing, this collaboration. Probably this is the right time, therefore. Sometimes we do things a bit prematurely. I think we, university, can have a e-learning platform which can do topics of professionalism, evidence-based medicine, preventing infection care, how to prescribe medicine on a evidence-based footing, how to prescribe different investigations. I think these are practical skills. I think sometimes many young doctors probably prescribe different investigations not out of malafide intention that I'm going to get commission, no, but because they are a bit puzzled. In our society, anything new is good. So anything new, why are we prescribing nitrofurantoin for urinary tract infection? I would prescribe a new generation of quinolone. I don't even know the name of the quinolones available in Indian market. Here in this country, I prescribe only 2 quinolones, ciprofloxacin and levofloxacin. And you got so many quinolones, gretifloxacin. I even don't remember all those names. I do not care even to remember, to know. You see, whereas I think 30% of urinary tract infection I hear treat with nitrofurantoin. Septrin, cotrimoxazole, nobody prescribes. We go for azithromycin, because that is seemed to be a bit latest, fancy, once a daily, or maybe something new totally. But we don't know why we're prescribing. If I ask you, any 10 of you I can select now, and I can be a teacher, very frightening teacher, and I will ask you, what is the spectrum of amoxicillin? Do you know? I think many of you would be dumb. You would not be able to answer me. If I ask you, can you treat MRSA with meropenem? I think 50% of you will say yes, and 50% probably would say no. Just a random, you would pick it up, So I think there is microbiology is a bit difficult because we practice it as a laboratory-based thing, but let us not be a microbiologist here. I'm making a general point. So I think we need to tightening up of our professionalism side of the things, dealing with patient, explaining these principles to patient, how we speak to our patient is a generic skill. It is not a disciplinary skill. Cardiologists need it, nephrologists need it, everybody needs it. So this is called generic skill, goes across the specialties. I think we can have a very sound modules, on an electronic, on an e-learning platform of these generic skills. These are well defined by Royal Colleges, so we can borrow from that. Royal Colleges curriculum are very, very good. Anybody entering into specialist training in the UK, they have to do this, generic skill competencies first. So these are ideas. So taking Romenda's point, I try not to speak about corruption and malpractice and things like that, because I am sad actually. Once upon a time I was very vocal, but at this point I do not want to be, I just feel very sad. So therefore I'm not going to speak on this any longer. Any other questions?
Sir, nowadays we know that many ethical issues are there, but a simple issue, if the patient, you told that if the patient is willing to die, but there are issues where people is not willing to die, but the family members are just pressuring for the death, and the doctor is in a big situation. What to do in that situation?
I think this is a very good question. You probably got the answer from the, from what we deliberated on euthanasia. If you are killing him, I'm using the word killing, it sounds bad, but what you are describing is a situation of involuntary euthanasia. Yeah, the person doesn't want to die, but you or the family is deciding for the person that it is better for you to die. So that is involuntary euthanasia, which is wrong, which is not permissible. Yeah, so that is very clear actually. There is no dilemma. You can't just because I want my father to die, because I think his life is not worth living now. But I may not be afford to pay for his treatment, you see. Then when you do, you are a private nursing home, somebody is on ventilator, and you see our context throws up new ethical dilemma. This dilemma is I do not face in the UK. Look at this dilemma. Somebody is on a ventilator, and you know the family now no longer can pay. What you do? What you do? Are you morally right to put him in a huge debt, and then now he has to go to his village, sell everything off? And I don't know what is the right answer. But the wrong that you may have already committed was that you didn't explain to the patient or to his parent or to his guardian that this is putting this patient on ventilator is a no-win scenario. Because as a doctor, I know this patient is going to survive only 5 days, and putting on ventilator is only going to prolong his agony by few more days and put him on a lot of disadvantages in pain. So probably I didn't explain that. You see, we can avoid moral dilemma by doing the right thing at the right time. So why we go to that? But again, that doesn't mean that this person hasn't got money. That's why, I tell him all the, wrong things and not to treat him, send him to a GMC rather than in my private hospital. That could be wrong as well. But what I am saying here, in 80% of the time, if we explain the scenario, the situation to the patient and to the family, I think we can avoid moral dilemma. But I tell you one cultural difference between these countries where I am and our country. I have seen here patient, the anesthetist, the ITU doctor, sitting calmly with the patient, explaining to him, Mr. James, you are going to die tomorrow. Do you want this saline to be given or not? So frank is the discussion. But in India, in our cultural scenario, the sensitivities we have, I don't think any doctor can discuss that kind of language with a patient. So then, in our scenario then, I make decision for my father. I make decision for my children. We always do. So maybe as a society then, we have to take a stand, isn't it? That a parent can make a decision for his children, even though the children is adult, and vice versa. We never, we do not speak certain things. We do not speak about death with, we always give hope, because that is how we are brought up, to give hope to even to a dying patient. We know, all of us know that I dealt with 2 relatives in last 2 months. In every situation I knew that the patient was going to die in weeks. So, and I know the patient wishes as well. I knew my father's wishes. He is a dignified person. He would not like him to be seen in a bed, helpless, unknown nurses giving him hygienic care. If he was going to get cured from that cancer, by all means, he would go through that agony. But if he is not going to survive, I know his wish. So my father, for example, when he died of his cancer, he was at house. My family. My brother is a big guy. We can go to any hospital. But we as a family took stand that no, Baba cannot go to hospital now. He is terminal. Let us all be by his side. It is let him. Let us. It would not be in his interest, and not only that, it would not be in his interest. He would not. I know his wish. You see, this is the dilemma I have told you. The wishes of the people when he was conscious, when he was competent. Let us take an example. A dementic person, a person has become dementic. He doesn't know now who he is. But he was a vegetarian. He was a vegetarian and he got a very strong religious sense that he is a vegetarian. He would never go by the non-veg. But now he got dementia. And he now, if he eats somebody eating chicken, he wants to grasp and eat chicken. Tell me what he would do. He already given a note that if I am to become dementic, please respect my wishes, my values. So his values is very explicitly written down that if I become dementic and if I do ridiculous thing, please prevent me. So this person would have never eaten meat. Now he has taken meat, started taking meat. What he would do? So this situation arises in institutionalized nursing homes where people are kept, in family also. In family, it might appear, I know my dad, he would never have eaten meat. Now he is asking for chicken. This is ethical things, what you do. And this is not a clear choice in this situation. I mean, the arguments goes either way. Very difficult. But my point is from the last question is that why shall we drag ourselves to a situation where we are in a situation to make a ethical decision? Why don't we do our right thing from the very beginning and avoid that kind of moral dilemma? I think that is the course we could take.
Dr. Sarma,
Babulda.
I have got two questions in relation to euthanasia. Very nice deliberation from your side, and we have known so many things. Now, first question is that if one person want to commit suicide, should doctors treat that patient? That is number one, because if we look through the patient's autonomy, that is number one. Second thing is that, second question, if is taking someone off from the life support, is it in euthanasia?
Yeah, no, I think your first question, I don't have the answer, but you have raised the ethical dilemma. The person wanted to die, he took a serious step. Now he didn't die, he was brought into the hospital casualty. So as a doctor, should you allow him to die? I think here you have to, it is a real moral ethical question. But all I can give you the practical guidance that you're probably the duty to treat him would probably override his wishes in this situation. That is, I am taking a stand, I may be ethically wrong, because you see, committing suicide is, sometimes we are bound by the law. Yeah, and law may not be ethical. For committing suicide is prohibited by law. So if you don't treat this patient, you are violating the law in a way. You are becoming what is called the assistant to a crime. From that point of view, for you, the safe practice is to treat him. But I totally agree that there is a big ethical question here. What should we do? So I leave it there because I don't have the answer. Because it has to be debated. It's if you go by the autonomy autonomy principle, you cannot. You should not interfere.
Hello.
Yeah.
Hello.
Yes.
Speak something. Jayanta.
Yes, please. Yeah, Deepak. Yeah.
This is a very nice presentation. And so now we are talking about philosophy as well as psyche as well as literature, everything is related. But when it comes to, I think, law and ethics, law will come first. Must take. That is the thing I think here.
No, I think law comes first in the sense that is the law of the land. And if you don't go by the law, you would be in the prison, as simple as that.
Yeah.
Yeah. But it is a very valid question. In fact, when I was reading about this, there was a real case in Australia. A doctor actually helped with euthanasia. Euthanasia is not legalized there, but he practiced euthanasia and he was brought to the court. The judge passed a judgment then I can't help. I see your point, but I am bound by a framework, so I have to give you penalty. But I can see your angle, I can see where you were coming from, but I have no option. You know,
You
so
are,
that is
you
the
are, you are
difference between
exactly
law
right.
and ethics.
Exactly right. So, for practical point of view, I think one should follow law. But this is a question of debate.
It is a
You are
question
right,
of debate. It is a question. If you are a
But-
very ethical person,
but-
you would probably go by your own moral
Yeah.
judgment.
But for practicing person, I think who is
For a practicing person, you have to go with law.
law.
But
Yeah.
sometimes law is considerate. Law sometimes allows that I'm not going to, as a judge, I may say that I'm not going to interfere. It's a very specialized matter. It is better dealt with the framework of the professionalism. You know, let a bunch of specialists, 5 doctors from different places come and let them take a decision.
Right.
You know, that is what the via media we usually court takes, you know, in difficult cases. That's what one of the points I mentioned, that sometimes ethical matters are left to the practitioners.
So I have said one point very clearly. That's very good. That is about cultural sensitivity. What is thought to be wrong ethically in one culture is thought to be right in another culture. That is a very important point. Even in India, it's happening because there we have many cultural communities, and now we have seen that many students are coming from different parts of the world. They are not culturally sensitive to our setup. So, do you think that cultural sensitivity should be trained to a student? It should be trained to a student so that he can take it ethical decision.
It is part of the generic skill that I was mentioning. You know, but we have to be careful at the same time. Some, you know, apparently culturally you may be different in terms of, you know, some differences are superficial. Like a Hindi belt person would usually, in our eyes, they sound a bit rough, you know, but that's the normal way of talking. You know, we have to be culturally sensitive as well to that person. So it goes either way. But so far it comes to dealing with patient, we need that professionalism. You know, what our ethics dictates, what our medical council norms dictates, you know, that should be trained. That part of the generic skill. But amongst ourselves, whether we should fight or not, we like or dislike somebody, that is, as a mature adult people, you know, we have to go by logic and judgment. Yeah. But it should be part of, I think, I think it is really good that we all, the teaching fraternity, you know, I think we should really be thinking about generic skill, develop modules, you know, and put it on electronic platform. Student can do it at any time. And all we need to do, we have to say them that you have to complete that within the first year. They complete it. They just produce evidence that you completed it. You may not examine it. You don't need to examine, but we can do that. I think Babulda has a second question. The second question, Babulda, what you were asking?
Actually, is taking someone off from life support.
Ventilator, yeah. No, that is permissible. That is permissible. Withdrawing treatment and not giving life-saving treatment is permissible. If you, as a doctor, you know that the patient is terminal. Actually, General Medical Council, the body in the UK, they define end of life as somebody who is dying within 12 months. Yeah, that is the general definition of end of life. So here we practice a end of life protocol, you know, but this is complicated. There are complications as well. In this country, the end of life protocol until 2010-11 was called so-called Liverpool Care Pathway. You may Google it, you will find it, Liverpool Care Pathway. That is the pathway of caring for a dying person. That pathway was criticized. That many people who probably would not have died, probably hastily been kind of put through that pathway. Because putting on that pathway would mean that you would not escalate treatment. There is a term called ceiling of care. Ceiling of care means that this person's ceiling of care is ward-based treatment. If he requires ICU, no, we are not sending him to ICU because his ceiling of care is ward-based treatment. Similarly, Here, even when person get admitted, they decide on whether they are going to give artificial CPR, cardiopulmonary resuscitation or not. It is decided even before patient, the moment patient is admitted. In certain situations, a panel of doctors would decide that it is not in his best interest, and he would not be given a CPR. And patient wishes is taken into consideration. Best interest of the patient and the first principle respecting autonomy, both usually they meet the points. Sometimes there may be a conflict, but 90% of the time people arrive jointly at a sensible decision, which we do not do in India. As a doctor, we are not frank with guardians, we are not frank with patients. Maybe that is because of some kind of cultural conditioning. We don't like to speak certain things, but sometimes I have got no doubt we go by our business interest. Very frank. I know for sure, corona patient who is bleeding, by looking at his face, you can know he got 90% saturation. You are keeping him in Medicity Medanto for 15 days. 15 lakhs bill. These are real cases. Unethical, because you are denying a genuine patient who really needs that bed, who probably is genuinely, got trouble, probably died because of a lack of a hospital bed. I know patient. I have been sent pictures of corona patient, this particular case. When I saw his photo, his father was so concerned, and my well-known, so they discussed with me, medical. He sent me a photo of his son in Medicity Medanto. His mask was hanging here, and he was in conversation with. So I got that video clip. The dad sent me. The Jayanta, he is in Medicity Medanto. Ki hobo, kwasun, tumar ki advice. Hey photo kon, moi microbiologist, moi anesthetist no hoy, moi clinical assessment moi koribo nwaru. But still, even as a layman, as a basic doctor, I know, first of all, the mask is not delivering any oxygen. Yeah, he is in conversation with his father. So that is evidence enough that he doesn't need oxygen. Okay, then one day, one of my anesthetist friend came to my house. He's an Assamese boy as well, junior to me. I showed him that photo, Okay, you can say it's a breach of confidentiality or whatever, but because it is a overriding issue of kind of clarifying my whether I told the right thing or not, he told me, Dada, this guy, we are anesthetists, we can look at the face of the people and we got an intuitive clinical judgment we can make that, who is suffering from lack of oxygen. This guy is having 99% saturation. Pink, his face is pink. You see, so this is what it is. We are fooling people. Medicity Medanto, the guy, the boss of that hospital, come into air and lecture us about third wave, fourth wave, and fifth waves. And bloody he is not doing the right thing in his hospital. You see, this is, we got, I mean, what to talk about ethics? We need to talk about criminality in medicine. Am I being too strong? You are not private practitioners, you are all teachers. So
Thank you, Jayanta.
So yeah, no, that's good. I think we can probably conclude. But I think from this, you as a group take a concerted action about a e-learning platform with generic topics of ethics, topics of professionalism, communication, everything come under professionalism. It would be really good actually if we could do that. And so many materials available, but you need a good kind of a committee, because following West is not the answer. How we adapt it to our sensitivities, our values, and so on. I think that is important. But what Romenda said about what to prescribe, we should have an uniformity. I prescribe A, you prescribe B, same condition. There is a medicine called chimeral fold. we know from our internee days, Deepak, don't we? Chimural 4. I think you prescribe it even right now. Very expensive. But nowhere in the world I found chimural 4, except in India. If it did any good, why these British people would not use it? Anybody coming to the casualty with a swelling of a traumatic nature, we write an antibiotic and chimural 4. I think even you do it today probably as well. So that medicine should be delisted from the formulary. It only costs money but delivers no good. So I think hospital needs a formulary that this is the list of drugs or brands. Actually, no brand should be entertained because every good company produces their generic counterpart. So I can write paracetamol within bracket, maybe, write the name of the company, the generic from Pfizer, rather than Calpol, I should write paracetamol. But to make sure that that paracetamol is from a good company, we can ensure that by stocking only good paracetamol by good companies. But there cannot be 10 branded of paracetamol that interns should be writing. Yesterday, I'm so pleased. One of my relatives was operated for a brain tumor in Guwahati Medical College. Just discharged home. I got the operative note, and I'm still to read it. Because the handwritten notes, so difficult to read. In Guwahati Medical College, we still use, the pro forma for medical tests. It was my days, when I was an intern there, the same WBC, RBC, we put ticks. It is the same kind of thing we use till today, It hasn't evolved in a radical, creative way to make it easy that if it is a hepatic kind of a problem, this is the set of bunch of tests we should be doing, not anything else. You can make it easy for the intern, for the junior doctor. Actually, it should all have been electronic. But even the paper form, I don't know, maybe it is changed now. And all your paper record, that what goes to MRD, the same stationery, that we used 20 years back. Definitely a stationery can be organized in a better way so that we can write the right things at right, we do not write unnecessary things, we are to the point. So many improvement things we can do. The audit, medical audit, I mentioned about our license renewing, every 5 years. If I do not do medical audit, I would not pass my appraisal, and that would interfere getting my registration renewed 5 years down the line. But we as a practitioner, we need to practice our own audit. Medical audit is it comes from government. The government insists, do that audit. It shouldn't be bureaucratic. It should be our professional thing. So I conclude here because otherwise it would go on and on me lecturing. So we'll do it again, in near future, and hope this series goes very well. And if the university decide to produce some kind of e-learning, I would be happy to help with things. So with that, I conclude. Thank you.